The first speaker is Dr. Manju. She is working as a glaucoma and phaco surgeon at Arya Eye Care. Over to you, Anju. Choosing the first line therapy, one size fits all.
Thank you, Dr. Saumya, for this opportunity. Choosing the first line therapy in glaucoma, what does one size fits all? So, how do we choose the first line therapy, or how do you decide which drug to be given as a first line therapy? One thing and most important thing is the target IOP which you choose for that patient according to the disease severity and age of the patient and considering various factors. And next is the systemic and ocular comorbidities of the patient, and what is the lifestyle of the patient, how he will be able to adhere to the medical therapy you are giving, cost and accessibility of the medication, potential side effects and tolerability. These are the factors which should be considered when you decide on the first line medication, first line therapy for the patient. Over a few of the medications, prostaglandin analog, adrenergic beta adrenergic blockers, alpha agonists, carbonic anhydrase inhibitors, and rock kinase inhibitors. If some cases we can give. First thing will be the prostaglandin analog. This is Laszlo Bito who invented prostaglandin analogs, and this was the journey of the prostaglandin analog, which first one to be invented is the latanoprost in 1995, and next is bimatoprost, tauprost, tafluprost, and the last one is a latanoprostine bunod in 2020. And these are some studies on prostaglandin analog. This one is a landmark study which is the first major multicentral trial establishing latanoprost. This established latanoprost as a safe and effective once daily prostaglandin analog, and leading to the widespread, and it has led to the widespread adoption of it as a first line medical therapy. Next is a comparison of once or twice daily bimatoprost with twice daily timolol in patients with elevated IOP, and this was James et al. And it concluded that bimatoprost 0.3 percentage one night, not the twice daily dosage, but one night dosage produced statistically greater IOP lowering than timolol. It had more IOP lowering than timolol and than the twice daily dosage. So, bimatoprost is one of the most established as one night therapy, and it's the most effective single agent topical prostaglandin analog. So, in which all conditions do we usually choose prostaglandin analog as a first line therapy? One and foremost thing is a normal tension glaucoma and POAG, primary open angle glaucoma, OST, and secondary glaucomas without inflammation. So, inflammatory conditions, we don't usually choose prostaglandin analog, and it's usually avoided in NBG due to its pro-inflammatory characteristics, uveitic glaucoma because of the same reason, and it's avoided in unilateral glaucomas because it can produce a prostaglandin associated periorbitopathy or periocular changes. Because of that, it's avoided in unilateral glaucoma, it's avoided in children and young adults because of the same reason, and it's avoided in pregnancy because it can precipitate early delivery. And potential side effects are conjunctival hyperemia, which can be transient, increased pigmentation of the iris, eyelash changes like increased length, thickness, number of the eyelashes, and there can be periorbital skin pigmentation and darkening of the eyelid or surrounding area, and can also lead to the prostaglandin associated periorbitopathy. This is one of the patient who was using prostaglandin analog unilaterally. You can see the deepening of the upper eyelid sulcus, there is enophthalmos, and compared to this side there is a little bit of a periocular hyperpigmentation, and here there is fat and there is a fat atrophy. So if you give prostaglandin analog unilaterally, there is a chance of an iatrogenic dysmorphism if given unilaterally. So this should be explained to the patient if you are choosing to give the patient unilateral prostaglandin analogs. And now there are advancements where you can have ocular inserts which release prostaglandin analogs on a daily basis, and it can be left in the eye for 3 months to 6 months. There is Durista and other periocular and ocular inserts of containing prostaglandin analogs. This is a recent invention. Coming to the beta blocker Timolol, it's given in various concentrations. It's a non-selective beta-adrenergic blocker. It decreases IOP by reducing aqueous humor production. Once or twice daily dosing is usually preferred. Can be used alone, or one thing is that when it is started as a first-line therapy, later it can be combined with other anti-glaucoma medication, and it's cost-effective and widely acceptable. And this is a study by Zimmerman et al. And it is a double-mass placebo-controlled trial which was done long back in 1977, and it concluded that twice daily dosage significantly reduced intraocular pressure without major or ocular or systemic side effects, establishing it as a first-line effective non-myotic anti-glaucoma therapy. It's usually preferred in POAG, OST, any kind of secondary glaucomas, and can be used in post-op IOP rise and even used in unilateral glaucomas. It's usually avoided in NTG because of this vasoconstrictive effect, elderly patients because it can cause bradycardia, bronchial asthma, COPD, and can also cause sinus bradycardia or AV block. It's avoided in lactating women because it's precipitated in the breast milk and can be transferred to the child. Avoided in children because of this bradycardia effect, and it is avoided in diabetic and thyrotoxicosis because it can mimic signs of hypothyroidism and glycemia. And which PGA versus these are the two drugs which is usually preferred, prostaglandin analog or timolol. Main thing is that cost constraint. If the patient has financial constraint, timolol is preferred. Otherwise, prostaglandin analog is the first line therapy. But timolol is something that is effective, affordable, and dependable if cost is an issue for the patient. And third one is a brimonidine. It's used on if prostaglandin analogs and beta blockers are contraindicated. It acts on the alpha-2 receptor of the ciliary and suppress aqueous formation. It can also increase UV scleral outflow. It enhances drainage to the UV scleral pathway. There is a rapid onset of action, so because of that it can be used as an acute control, like in the case of a post-YAG PI. It has a little bit of a neuroprotective action, and it has addictive effect over other agents. So side effects is follicular conjunctivitis, dry mouth, and CNS suppression. And the drug of choice is if prostaglandin analog and timolol is contraindicated, unilateral glaucoma in a bronchial asthma patient, NTG, post-YAG IOP rise is avoided in children, drivers, and in allergy. And next is a dorzolamide, which is safe for patients who can't tolerate beta blockers. And side effects will be like ocular burning, stinging, bitter taste, superficial punctate keratitis, allergy, or hypersensitivity reaction. Usually, drug of choice if PG and timolol is contraindicated, unilateral glaucoma in bronchial asthma patient, NTG, and children, and avoided in compromised cornea. That is one thing, and should be avoided in early pregnancy because of this teratogenic effect and allergy if there is allergy. ROCK kinase inhibitors usually preferred as a first line therapy if there is an elevated episcleral venous pressure and there is little bit of a corneal edema. There are I will skip this, and take home messages are prostaglandin analogs remain the first line of choice in most of the patients. Timolol is a cost effective alternative option. Carbonic anhydrase inhibitors, alpha agonist, and ROCK kinase inhibitors are valuable other alternatives. You should always, whenever you start a first line therapy, you should always reassess IOP and see for the side effects 4 to 6 weeks after initiation. Individualized therapy based on systemic and ocular comorbidities is important. So there is nothing like one size fits all. Thank you.
Thank you, Manju, for